Hello. Welcome to part one of our four-part series on documentation. My name is Henry Williford. I'm on staff here as adjunct faculty with Southern Union State Community College. And our goal in this series is really to prepare you, the student, to be able to provide professional level documentation both during your clinicals and once you graduate and you're out in the field. We're going to get started here in just a minute, but my goal during these four little lectures were to kind of keep them concise, keep them pretty short. I realize watching lectures online can be a little bit difficult to follow. I'm going to try to make them as interesting as possible, but when you're watching a little video, I understand that could be quite difficult. So we're going to go ahead and move along here, talk a little bit about what we expect. Let me see. All right, kind of as an introduction, I'm going to try not to read everything verbatim. I wanted to make these PowerPoints where you guys could keep them as a resource by themselves, and they would be a good resource without listening to the audio, without watching the video of it. So I'm going to try not to read everything, although I did want to include a lot of information actually written on the PowerPoint. So just bear with me. I'm going to try to kind of skip over things, but we'll make this work. As an introduction, this series is done with the assumption that you are already familiar with what is important to document when caring for patients with different chief complaints. Therefore, we will not be covering what is important to include or exclude in every given situation. You will learn what is important to focus on and document as you cover that specific topic. So for your chest pain patient, we're not going to cover everything that's required in your chest pain patient versus what's required in a respiratory distress, in a cardiac patient, what happens whenever you begin to intubate, all these different things that are very important to put into your documentation. We are kind of doing an overview, and we're trying to make it very broad, so that way all of our students, from our EMTs to our advanced, all the way up to our advanced paramedic level, all of them can benefit from watching this series, and nothing will be too advanced or too over the top for someone's education setting. Another goal of this series is to prepare you, like I said earlier, to write on a professional level, clear and concise documentation that both in your clinical setting and when you transition to the professional world. I did say that earlier. All right, in this first lecture, we're going to cover a few different things. Kind of to get us started, we're going to cover why do we document patient care, period. Why is it important that we actually document? We're going to go over a few strategies to help you improve your documentation. We're going to talk about our legal responsibilities as healthcare providers. We're going to talk a little bit about patient privacy and what HIPAA actually is. And we're going to cover just briefly how to make corrections to your report. So first off, why do we document? What is the purpose? Why do we do it? And my first response is always that documentation is a continuation of your patient care. And I believe that viewpoint is really what holds me. And if you can grab onto that paradigm, that viewpoint, it's really going to help you focus in and make your patient documentation a priority, realizing that your patient care doesn't stop whenever you drop your patient off and give your report in the ER. Writing that documentation helps the caregivers that come after you know exactly what you did without having to repeat a lot of your assessments. They can look at this thing and get a lot of information if it's done correctly. You're communicating your care and crucial details about the scene to the receiving staff. That's a lot like what I just said. They need to be right there so that way they can see what it's like whenever you picked them up. What were they looking like? What kind of care did you give? What routes did you go down that you realized maybe it wasn't actually that? We have to remember that you're always the patient advocate, and in your documentation, this is your time to make sure that the patient gets the best care that they could possibly get. Through your documentation, you can show and help lead others down the right path. A few more things is proper documentation is your best defense against lawsuits or questions about your quality of care. If you're ever brought into lawsuits, which we're going to deal with a little bit later on, your documentation is going to be what you have to one, refresh your memory, and also to show, hey, that you gave high quality healthcare. Another reason is that it reflects your credibility as a healthcare professional. You'll learn as you get in the field, you begin to build a repertoire, a reputation with receiving facilities, with different nurses, with different doctors, and your documentation helps to nail that in. They may be busy and your verbal report might be a little bit abbreviated, but when they read your report, they're going to see that, one, you did what you were supposed to, you gave a quality assessment, that your treatment was appropriate, and all these things. They're going to begin to trust you, and your reputation is going to be built if you do proper documentation. Another reason is obviously compensation. That's not something that we really see a lot of in the clinical side, but whenever you begin to work, all of these agencies are in it for a profit, and they're able to bill insurance companies based on what you actually did. And if you didn't document it, then you didn't do it. That's a phrase that we'll see repeated throughout this. If you didn't document it, you didn't do it. So it doesn't matter if you put the patient on oxygen, they can't bill for that nasal cannula or the oxygen that you used if you don't have it in your report. Okay, a few other reasons. Documentation provides an avenue for review of your patient care and quality assurance. A lot of agencies, they like to go through the reports and help to see kind of what they can improve on, where they might need more training in, and make sure that their healthcare professionals are doing just that, being professional and providing good quality healthcare. It provides an avenue for continued education. When we document, we learn everything. You will learn just as much, if not more, once you get out in the field as you did while you were in school, that's for sure. And then another one that a lot of people don't really think about, but I feel is very important, is our documentation provides data for institutions researching how to provide, how to improve healthcare. I have two examples here, the American Heart Association and the American Academy of Pediatrics. The American Heart Association does ACLS, the American Academy of Pediatrics does PALS. Both of them have gotten so much research. For example, American Heart Association hasn't been around for very long when you look at the grand scheme of things, but through their studies, they have improved cardiac arrest rates dramatically. And they do all that by studying hundreds and thousands of cases specific to what they're looking for. Okay. Now I'd like to talk to you about some strategies for your documentation. Here's a few things that can help you improve your quality right off the bat. So these are some good intro kind of information here. Documentation is good, one, when it's accurate, when it's precise, when it's comprehensive, when it's legible, when it's objective, timely, and also unaltered. And developing your documentation skill is as important as any other patient care skill. I believe documentation is just like starting IVs. You need a lot of practice at it. And as you get that practice, you're going to be fine-tuning those skills, whether it be IVs, patient assessments, whatever it may be. Documentation is just like that. And it's a skill that needs to be honed. It needs to be polished and refined. And if you can stick to these objectives right here, they're very general, but if you can kind of run these over in your mind while you're doing your documentation, it's going to help you become better at writing narratives about completing PCRs, okay? Whenever you are going into it, it's great to have a plan before you ever sit down to actually write your documentation. While you're giving patient care, while you're doing your assessment, while you're en route to the hospital, it's good to already be thinking about how you're going to be documenting things. I suggest carrying a notepad with you and taking notes as you go along. A lot of places, they take clipboards, they provide sheets broken down to help you as you kind of lead you through your assessment and to take notes. But I always suggest just carrying a small notepad, so that way if you leave that in the truck, if you're in a situation where you don't really have that, I used to write on my gloves all the time, and I found the first thing I did whenever I went in, I gave my report, I'd take my gloves off and throw them in the trash, and then boom, I lost my first set of vitals or whatever, patient history I had written on that. While you're on scene, go ahead and gather any information that you're going to need before you leave. Go ahead and get a sample history. Of course, it's going to depend on your patient. On some patients, we don't have that luxury of spending a lot of time on scene. However, if you have the time, go ahead and get that stuff while you're there at the house. Obviously, if you need the patient's medications and you're already en route to the hospital and you didn't think to get them, well, now you're out of luck. You can't just turn around and go back. Anything that you may need from bystanders or the family, it's good to go ahead and get. Another thing is its readability. People don't really think about that because we do a lot of our documentation on computer programs now. However, it's really important, and it's just as important now as I would say back then. It's not just your handwriting that needs to be legible. It's how you write, your sentence structure, your spelling, using appropriate abbreviations and proper terminology. Right now, in the paramedic book and in the advanced book, there's a few lists, and I think I may put some online as well that go over some approved abbreviations. HTN for hypertension, DM for diabetes. In the paramedic book, it is on page 133 through 135, and in the advanced book, it's on 145 through 148. I wasn't able to find any in the EMT basic book. However, I'm sure there's some in there. I'm sure your teacher will go over that with you as well. But I'm going to try to put some online. I believe I have a few PDFs that have some on there. And go ahead and be reading over these. And these help you shorten your abbreviations. They're approved. They're universal, depending on regardless of what facility you go to. And this really helps to kind of keep everyone on the same playing field. If you start making up your own abbreviations, your own shorthands, that can really be detrimental because what you mean it as, someone else may take it as something different. So keeping with those, I would really suggest looking over those. When I review your documentation, that's what I'm going to be looking for. If you have an abbreviation in there, I'm not going to care as long as it's approved. But if it's not approved, you're going to have to go back and fix it, okay? A few more strategies for documentation. You need to complete your information. You don't want to just have a half-written report. You want to make sure that you fill in all the fields. You don't want to leave anything blank. Now, as you do your report, say you get to the section where it talks about, I can't think of anything specific. So let's say, excuse me, let's say it talks about the cardiac arrest section, but your patient never actually went into cardiac arrest. You still need to put some information in there, especially if it's something that may be related to your patient. Obviously, if it was just a transfer, the patient hopefully won't be going into cardiac arrest. But we need to put NA or not applicable, put something in that slot so that way it shows that you looked at it, that this didn't apply to me, and it also prevents any kind of alteration later on. We want to assure that any documentation is accurate. You don't just want to try to remember. If you're unsure of things, you need to state that you're unsure. There's different ways that you can phrase things to show that it was you weren't 100% sure of it, or just overall just leave it out. And as you do your documentation, go ahead and try to find your rhythm. It's important to kind of get in the flow of things using things such as the chart method, which we'll talk about a little bit later. Things like that help you get into a rhythm. So all of your narratives, they're specific to that call, but at the same time, they follow a pattern. So you know you're going to start off chart. You're going to start off with your chief complaint, and you're going to go into your history. You're going to do your assessment. You're going to talk about how you did that, what kind of treatment you did, and then transport to the hospital. And if you can find yourself a rhythm and you can be consistent, it's going to help you from one narrative to the next. You want to make sure that you attach any kind of supporting documentation that you might have, such as an EKG, any kind of patient medication list that they may have had, notes about your vitals or other healthcare professionals. Say you got on scene and first responders had already done some sort of care, and they hand off, say, their on-scene set of vitals. You want to attach stuff like that if it's supporting your assessment and your documentation. You want to make sure that you include that into your documentation. Okay. Now, next, I want to talk to you about making changes to it. There is a specific way to do it. Even, of course, it varies from writing to digital, but there's still specific ways that we need to do it. Making changes. If you correct something, make only, this is in the writing section of something, you want to make only one line through it, and you want to initial that correction that you made. If you're going to mark something out, only one line. You never want to use pencil to scratch or to write something where you could erase it. You never want to scratch something out with a pen, such as just, one line lets everyone know I didn't mean that in there. 5 lines doesn't mean, you really, really didn't mean that to be put in there. And of course, you never want to white out something. If you ever have something and it goes to court and there's pencil marks where you were erasing, something was scratched out or it was white out, or some kind of correctional fluid was used, lawyers are going to look at that and try to weasel their way around something and see what were you trying to hide, what was so bad in your documentation or possibly in your patient care that you needed to hide it by scratching it completely out or using something like correctional fluid. We don't use paper in our PCRs a whole lot. They're still being used, but they're not quite as common. Digital is a lot more common. And when you do that, you want to, if you're using a specific program, follow the protocols that are in that specific program. But if not, if you are submitting something later on, you want to make sure that it's on a separate sheet, and you always want to state why you needed to correct yourself. If, say, you said the injury was to their left shoulder, but it was actually to the right shoulder, you need to just put, hey, I forgot. Do it through the proper means. Add that separate sheet to it saying, I was wrong when stating that the patient's left shoulder was dislocated. It was actually the right shoulder. Initial it, sign it. Or if you forget to put something in there, you want to state, hey, I forgot it, but this is true. This was part of my assessment, and follow the proper means through that specific program, through your department's protocols and all of that. Legalities. As a healthcare professional, as an EMT, you are legally responsible for a few things. And a lot of people don't realize it. I believe now with the increase in lawsuits, people are beginning to realize it a lot more. But your PCR, your narrative, is a legal document. It's not somewhere where you need to try to be funny or really not take very seriously, because it is a legal document. Your report can be brought up, say in a lawsuit. It depends, on the statute of limitation from state to state. But in some places, as many as 10 years after the call actually took place. And, you may not remember that. You may not remember that call if you're working full-time hours. I don't remember very much about 10 years ago, much less some specifics about a call. Now, you are always going to be responsible for what's in your report. You're responsible for what it does say and also what it doesn't say. And here's that phrase again. Remember, if you didn't document it, you didn't do it. So say you have a patient, a severe trauma patient who's ejected from a vehicle, and of course in your head that you would have never transported a patient like that without a backboard and a C-collar, but you somehow forget to document that. If it's later on down the road and it's not in your documentation, you saying, oh, well, of course I would do that, they're not going to just take your word for it, especially if you're being brought up for some kind of spinal injury. So you want to make sure that you're very thorough with your documentation, and remember that phrase, if you didn't document it, you didn't do it. Like I said, your PCR is a legal document, but it's also a part of the patient's permanent medical file. So people can go back, everyone has their right to access their medical files. They can go back and review it personally. And also other healthcare providers such as doctors, if there's some kind of continuation where they have to go and do rehab for an injury or something, they're going to be looking back to see, hey, what actually happened. They're going to be able to see your documentation. And if you have sloppy documentation, it's going to reflect on you. It's going to reflect on your service. And with it being a part of their permanent medical record, that's not something that we want. Here's a question. When you're thinking about, it's 2 o'clock in the morning, you just went to a wreck that wasn't really super serious, but you had to transport. Ask yourself this question. Do you think you're going to remember that call in 6 to 7 years? And are you willing to rely on your memory to get you through a court case, or would you rather have the assurance of knowing that you took a little bit extra time, even at 2 or 3 in the morning after running calls all day and night, to write a quality report? I'm going to take the quality report every time. I don't trust my memory to remember what I had for breakfast yesterday, much less the specific details about a call 5, 6, maybe 7 years later. Okay, I'm not going to let my livelihood or my reputation, or really that patient, hang on just my memory. Next, I'd like to talk to you about HIPAA. HIPAA is something that we deal with pretty commonly in EMS, and HIPAA stands for the Health Information Portability and Accountability Act. HIPAA was established in 1996, and it did a few things for healthcare, but the one that we deal with the most is how it protects the patient's rights, how it protects how we share their information. HIPAA prevents patient information from being shared with non-essential personnel and others that may not be hospital related. And HIPAA does this by imposing hefty fines as penalties. Upwards of hundreds of thousands of dollars. And many places, departments, hospitals, EMS agencies, you can lose your job. And in some states, depending on how severe it is, you can lose your license for violating HIPAA. So we don't want the bill. We can't afford that kind of bill. And 2, we all care about a job, and we don't want to lose it over something as silly as not being very careful with a patient's information. Something to kind of help you out. I'm sure that your teachers at this point have covered a lot about HIPAA. I know that we cover it in class, so I'm not going to go into specific details about specific fines, the different levels of violations. You should have already covered that. However, something that I find is really helpful when dealing with patient information is to ask yourself, is it crucial to this patient's quality of care that I share or gain access to this information? If you're coming back to this station and you want to talk about, hey, I just had this bad wreck, this is what was going on, you never know. We'll be surprised at the people that know each other. You never know really what's going on. That alone can be considered a HIPAA violation. Obviously, we think more along the lines as far as someone calling on the telephone and asking for information. We understand that that's a HIPAA violation, but just being flippant about how you are talking about that information, say you're out at dinner. I've heard one story, paramedics go out and they're getting a meal, and they're talking about this wreck that they just went to earlier in the day, and they're just kind of talking about, hey, what was going on and stuff, and the patient actually died. Some paramedics have a pretty morbid sense of humor, so they were saying some off-colored things, and the patient's uncle was actually sitting behind them and didn't realize that his niece had passed away that day, and was hearing them just talk about all these things. And when he found out, those people were sued, and they lost their jobs for it. So this is really not something that we want to be very casual about. If you start healthy habits about dealing with patient information now, and you ask that question every time you have to access or share some information, is it crucial to that patient's quality of care that someone gets this information, or that I get this information? Then you'll be doing better off as you go along. HIPAA also allows for a few other things other than just their quality of care as far as getting access to it. It provides means of doing clinical review and practice. I can read your report about what happened on during your clinical because we're using it in an educational setting. HIPAA also allows means where the information can be used during training, again in school. It also, you can share information for billing and then quality improvement and quality assurance purposes as well. When in doubt, it's always better not to share that information or contact a supervisor or medical director when you're concerned about sharing that person's information, whether you should or shouldn't do it. Any information that could link you to a specific call, patient, or location should never be shared and may be considered a HIPAA violation. We really need to just avoid, social media is exploding in our day and age, and really we need to separate that from our clinicals and our social media. We need to separate work while we're working in the field, school and clinicals. All those need to be two separate entities. You never need to post anything on social media. You may feel that your entire life is taken up in school and work and all of that, and you feel the urge to document every little thing on Facebook or some other social media. You really need to exclude that, okay? And definitely for our school's purposes, you are never allowed to post anything. Most places monitor that. I know that the hospital that I work for, they have people that their full-time job is just to monitor social media, and it's worth them to pay them a full-time salary to avoid those HIPAA fines and prevent things like that from happening. For our specific clinical purpose, you are only allowed to record the patient's age, their gender, and their ethnicity. That's all you're going to need when doing your report online. I don't need to know names, anything like that. Copy of patient records. For example, if you take a copy of their ECG and it has their patient information up at the top of it, that could be a HIPAA violation, and we should never do that. We're never going to need their social security number, their name, their birth dates, or any kind of patient identifying numbers. Those, when you work in the field, we're able to obtain those for billing reasons, for a number of reasons, but for our clinical, in the clinical setting, we are never going to keep any of that information. Another thing is that you are never allowed to take photos during your clinicals. We've obviously all seen photos during school of specific injuries or accidents. There are laws that go with that, and we are just going to avoid that completely. With or without the patient's permission, we are never going to take photos, and those will not be tolerated during your clinicals. And that ends our lecture number 1. I hope that this wasn't too boring for you. My goal is to keep all of these lectures under 30 minutes. I've tried to keep the slides numbered to about 15 or less. So I hope that this has given you kind of a good introduction to documentation. We're going to cover a few more things over the next 3 lectures. And then we're going to have a test at the end of each of these. You should see these online. However, I have these posted. You should see a link to your first test. I would suggest go ahead, take that while this is fresh on your mind. I've tried to make those fairly easy for you. They're all about 10 questions long. So just go ahead, go over there, take that quiz before you move on to the lecture number 2 while it's fresh on your mind, okay? All right.